Good morning. Welcome to the final NIH Medicine Mind the Gap seminar of 2012. Today's featured speaker is Tanielian, who will discuss the concept of psychological resilience and highlight how the U.S. Department of Defense has implemented programs to promote psychological resilience in an effort to prepare troops and their families for the challenges of deployment. She will also review how these approaches have evolved over the past several years and how the concept of total force fitness is shaping future training and prevention efforts within the military. Ms. Tanielian is a senior analyst at the RAND Corporation. She received an MA in psychology from American University. Her areas of interest include psychological effects of combat, terrorism, and disasters, psychological resilience and suicide prevention, as well as access to and quality of behavioral health care for returning veterans. Ms. Tanielian has worked on several studies on the behavioral health-related needs of returning Operation Enduring Freedom, Operation Iraqi Freedom veterans and their families, including co-leading the landmark study, Invisible Wounds of War. Ms. Tanielian is currently leading a new prospective longitudinal study to follow military families across a deployment cycle and is also lead on a study to assess the veteran support programs under Welcome Back Veterans Initiative. She is serving as a co-investigator on a large randomized controlled trial to examine the effectiveness of stepped care for post-traumatic stress disorder and depression within the U.S. Army, and has published several peer-reviewed articles and book chapters and served on numerous working groups and expert panels. For those of you joining us today via webcast, we will be live tweeting today's lecture at NIH Prevents, and we will take questions using the seminar hashtag NIHMTG. Thanks to the NIH community and the leadership of the Office of Disease Prevention Acting Director Paul Coates, we've enjoyed our most successful year to date. Among this year's topics, speakers discussed biases in biomedical research, making progress in eliminating health inequalities, and communicating possible harms and benefits of treatment and lifestyle. We've begun scheduling speakers for 2013. If you have speaker or topic suggestions, please feel free to tweet us, use our seminar hashtag, or contact me, Paris Watson, at watsonpa@od.nih.gov. Now, please join me in welcoming Terry Tanielian.
Well, thank you for that wonderful introduction, and thank you for the invitation to be here. Thank you for all of those who came, and thanks to those who are watching and listening on the web. I'm honored and humbled to be able to share some of the insights that we've learned working with the military over the past several years about the concepts of resilience and kind of how they're moving and evolving to really think about these issues over time. Back up one second. I just want to ask, I see a couple of uniforms in the audience, but before I get started, I just wanted to get a sense of how many of you have worked for the military, been in the military, or are familiar with the organizations and cultures of the military. So a good number. So today I'm really going to be talking about issues that have affected the U.S. Army, the Navy, the Air Force, and the Marines, as well as to some extent the Coast Guard, which also falls under the purview of the Department of Defense. So I think it goes without saying that most of us recognize that the past decade of these conflicts that the United States has been involved in Iraq and Afghanistan have placed an incredible burden and exacted a major toll on our troops and their families. They represent the longest period of prolonged combat for the United States. Certainly, in the use of the all-volunteer force, we've seen an unprecedented reliance upon the reserve and guard, kind of our citizen warriors, if you will. We've deployed close to 2.5 million individuals. Many of them have gone multiple times for varying lengths, and they've accumulated numbers and numbers of months away from their families. We expect our military servicemen and women to perform optimally. We place them in austere environments. We hope and count on them to complete their mission efficiently and effectively, and to really be able to endure a very, very stressful work environment and life. We know that we can screen individuals to ensure that we get the healthiest and most competent individuals to wear that uniform and perform those missions. And we've seen over the past decade billions and billions of dollars being spent to really support those servicemen and women and their families to be able to really endure these stresses and perform optimally. So today I hope to cover a few topics. I want to talk a little bit about resilience. What is resilience? We've heard a lot about it. We certainly have heard it in different contexts. And there's a big hope and expectation that it is going to be a solution to many of the ailments that are affecting our troops. Then I'll talk a little bit about how resilience is being promoted. Can it be promoted? We'll look to the literature to try and understand what the evidence suggests in terms of really shaping and promoting resilience among populations. I'll talk a little bit about what DoD has done to implement some of those programs and their experience to date. And then I want to talk a little bit about a relatively new concept called total force fitness, which builds upon resilience and performance optimization and is shaping some of the new programs for the services in the future. And then hopefully we can talk a little bit about the implications for non-DoD settings and populations, as those of you are thinking about other at-risk groups for stress and other problems, and think about what in the military's experience and the resilience world may be relevant. First, I want to start with kind of defining resilience, and first perhaps kind of recognize that resilience is not a synonym for health or well-being. Resilience, in fact, has several definitions in the literature. We identified 37, in fact, but some of the most common ones are really the idea that it's the ability to withstand, recover from, and grow in the face of stressors and changing demands, or it's the ability to bounce back from a difficult experience in a healthy manner. So these two definitions really reinforce the concept that resilience isn't identified or determined until an individual or a group or a family endures some stress. So it's not a kind of point-in-time assessment of well-being. It's a process in which they actually bounce back or can endure a significant stressful event. Resilience factors are often referred to those individual and contextual factors that facilitate resilience. And in fact, in many observational studies, that's where we see various different characteristics that have been assessed to differentiate populations that seem to do well and from the populations that don't do as well. But there are some key assumptions that I think have been made in putting kind of a lot of eggs in the basket of resilience promotion, and those assumptions are that it can be learned and that it can be enhanced. If you look to the literature where resilience was actually developed, kind of from child development, there's been some belief that it's a personality trait, where others have seen that it's something that can be developed and nurtured. So why resilience in the military context? There's been unprecedented attention to the post-deployment mental health problems that our troops have returned home with, how these consequences then affect their families. There's been a number of concerns about the rising rates of suicide. So we've seen the stress accumulate. We've also seen the rates of these problems rise. We know that most personnel actually do well coming home from deployment. Only about 20% at any given point in time of our returning troops report symptoms consistent with diagnoses of PTSD or depression, although the suicide rates continue to rise, and that is certainly an area for concern. But there is a large proportion of our force that's deployed several times that seem to be doing okay. So what about those troops kind of can help us and teach us a little bit more about resilience? We know, as I mentioned, the billions of dollars that have gone into creating and implementing programs to promote resilience. They've really focused on trying to enhance coping skills, teach techniques that can promote resilience and kind of develop that hardiness, and now establishing these comprehensive models for fitness and then implementing various different holistic approaches to support those models. So kind of want to move to some of the work that we've been doing at RAND to help the military understand and evaluate kind of the various different efforts that they're focusing on. And I just want to kind of put out there what our definition of resilience is and how we've been approaching it at RAND. And it really is this capacity to adapt successfully in the presence of risk and adversity. And so thinking about the various different programs and services that are designed to increase an individual's, a family's, a unit's, and a community's capacity to successfully endure and persist through that risk and adversity. I present this continuum because it's used by the Department of Defense. It actually was adapted from the U.S. Navy and now used by the Defense Centers of Excellence to kind of indicate that, you know, you can understand resilience along a continuum. And they use kind of the green, yellow, orange, red kind of differentiation between folks that are performing optimally, people that may be reacting in the yellow zone. The injured is kind of in the orange-reddish, and the ill would be in the more severe end. And the idea that they use the 3 R's of resilience, reintegration, and recovery, and think about the various different ways that they can influence resilience through different types of programs, education and training, risk mitigation, stress intervention, and then treatment and reintegration. And that the concept of resilience isn't just meant for people in the optimal functioning area, but that you can think about resilience along that continuum and promoting it for the entire population. So now I'm going to talk a little bit about what we identified in the literature about how resilience can be promoted. In 2009, we were asked to examine resilience programs and identify kind of what were best practices. So before you can label something a best practice, you obviously need to understand kind of what they're doing, if it's been evaluated. And there weren't necessarily any gold standards for like the magic bullet or the solution for what had to be done to promote resilience. So we reviewed the literature to try and understand what studies had been done to identify and promote psychological resilience. And we also consulted with a series of experts to identify what we called evidence-informed factors to promote psychological resilience. A lot of these factors come from the literatures that have studied populations exposed to risk and adversity and differentiate between the group that does well and the group that doesn't so well. We've seen very few gold standard RCTs, randomized clinical controlled trials, to be able to take two groups, provide an intervention, and expose them to stress to see how one does compared to the other. Ethically, that's not necessarily something that can be implemented, and it's just more difficult to do those types of studies. Oops, it's going too fast. So we then identified these factors and then tried to apply them to the programs and practices and strategies that the Department of Defense was implementing at the time to promote resilience, to identify where there perhaps are some gaps and make suggestions for improvement. We also identified some models for the department and some of the services to think about for future programming and improving their own existing policies in this area. I first want to talk a little bit about the layers that we considered to kind of interpret these studies and examine kind of the process of building resilience and kind of how resilience bears itself out. We used a kind of ecological approach. If you think about, you drop a pebble in the water and it ripples out, how far it ripples and the strength of how it ripples can be modified based upon the density as well as how supportive that environment is around it. So we place the individual at the center, the family kind of as the next layer, the community, the unit actually is the next level, kind of their command climate and those that surround them on their unit, and then their community. And their community can be their neighborhood, it can be church group, it can kind of be kind of the next layer of reinforcement. So we both looked to the literature to identify factors at each of these levels, as well as then looked at programs that try to affect each of these levels in promoting resilience. So now I'm going to try and walk through each of these levels to share with you what we learned from the literature in terms of where the evidence and the strength of that evidence is strongest for promoting resilience. And so here we have the individual level resilience factors. And this table is actually ordered so that those factors that have the strongest amount of evidence from the literature are at the top, and those that come from with the weakest or perhaps just from expert insights are towards the bottom. So positive coping. We all know that it's important to kind of use positive coping techniques over negative coping techniques. You can think about help-seeking behaviors, the ability to kind of solve problems both personally as well as interpersonally in relationships. Positive affect, the idea of being kind of glass half full, optimistic, having a sense of humor when you approach challenges and difficulty, kind of being active and alert. Positive thinking, trying to kind of reframe issues, make sense out of a situation, thinking about positive outcomes versus negative outcomes. Again, that glass half full. But realism, kind of mastery of the possible, knowing your self-esteem and worth, having confidence, self-efficacy, and perceived control over a situation. Behavioral control, the ability to monitor, evaluate, and monitor your own emotional reactions to accomplish a goal. The issues around self-management, self-regulation, and kind of self-enhancement. Physical fitness, just the ability to actually function effectively and efficiently in various different domains and environments. And then altruism, kind of the selfless concern for the welfare of others, kind of putting others first. And so, I think that, again, these are characteristics that have been identified in populations that seem to do well after being exposed to stress or experiencing something very stressful. And to the extent that they're then adopted into specific programs, we'll talk about that in a couple of minutes. So to the next level, we have the family. Again, and so what we've observed from the literature and kind of the experts is this concept of emotional ties, the bonding among family members, kind of the opportunity to have shared recreation and leisure time, how close-knit your family is. Communication, kind of a very important concept in families, and one that kind of allows for the sharing of thoughts and opinions, where people in families feel that they can work together to problem solve and manage their relationships and stress. Support. Do you have support? Or do you feel comfortable and supported emotionally and derive comfort from those relationships in the families? Closeness, love. This gets at love, intimacy, and attachment. How attached your family is. Nurturing. This is particularly important around parenting skills. And kind of, are you nurturing of the other individuals in your family? And adaptability. How well can you adapt to changes, particularly the changes associated with military life across a deployment cycle, where tasks and roles within the family may have to change and shift across a deployment cycle as that service member deploys or has to go away for training. Other parts of the family may have to take out the trash, do other types of functions that service member took care of, getting the car maintained, or the carpooling, the homework supervision. So how adaptable is the family to being able to switch these roles? At the unit level, there have been several studies that have demonstrated the importance of the command climate and the amount of unit cohesion that can be protective in reducing the incidence of mental health problems among those who have gone to combat and experienced kind of stress. Kind of fought the idea that you can foster this inter-unit interaction, kind of the pride and support in the mission, the positive role modeling, the relationship that the individuals have with each other, as well as with their command structure. The non-commissioned officer level turns out to be a very critical level of leadership for most troops, in that, do they provide a supportive, kind of positive outlook and reinforce a good climate. The amount of teamwork, the ability to work well with your fellow unit members, and the cohesion. We often hear that in a unit they work very tightly and together to kind of accomplish their mission, but also look out for their fellow service member. Kind of the concept of "I got your back," "got your six" in military language. And so then the community. We have to recognize that the community also is a critically important population when we think about supporting our servicemen and women and their families. Kind of how well is that together to kind of get something accomplished, to really ensure kind of the success and coping with the environment, with the storm, stressful experience. So again, I think many of us can think about ourselves as part of the community that surrounds our service members and their families, and how well we interface. So these are the factors that the resilience literature has identified as being important. We also then looked at kind of, how is it best to actually confer these types of approaches or characteristics? And, is it just is easy to tell people about it, or is it about teaching techniques? And so the literature also shows us that it's about teaching techniques, and the highest benefit seems to come from those approaches that try to teach skills or strategies that will allow people to have a higher positive aspect, affect, to positive thinking, coping, again, positive coping skills over negative coping skills. So negative coping skills in this way would, be thinking about things like self-medication or denial. Positive coping would be things that, are more active and healthier. Realism, behavioral control, again, the techniques that have shown to be the strongest in promoting resilience. Kind of, again, this positive command climate. There's a lot of focus in the military about effective leadership, and are we really teaching and helping our leaders to really lead and be supportive of their units. And again, this sense of belongingness. So I want to talk a little bit about the various different programs, and I put this slide up just because I'm going to start to talk about these different things down at the bottom, these typologies of different programs. And there are several. Education and training, kind of the concept that we want to strengthen and prepare individuals and other groups of audiences to be ready for enduring some stressful life experiences. The risk mitigation, so we know something's happening, the ability to assess. The being able to identify and intervene with combat stress intervention. So this is heavily focused on individuals who are going to deploy and experience or be exposed to combat. And then treatment and reintegration, so kind of the treat. So when we look at the typology of education and training and look at the different programs that are put in place, we find that many of them are often implemented as part of pre-deployment preparations. The audiences may be for the individual service member. There may be activities designed for the family, designed for the children. There may also be things targeted specifically at healthcare providers or at leaders or at different types of audiences and groups. Historically, these have been called different things. Now the common term is resilience training. In years past, it was considered stress inoculation, the idea that we could inoculate troops against stress so that they would somehow be, hardied and ready to endure those stressful situations. Methods have varied greatly across these different types of programs. We see everything from briefings of PowerPoint slides that sometimes can go on for hours and just be repeated information put up on the screen, classroom style. And I was able to attend an event not too long ago in a guard unit where we were in this very stark large warehouse, sitting in chairs, having slides just repeatedly shown to us to talk a little bit about wellness and stress prevention. Or they may be simulation drills and field training exercises to prepare individuals for the types of experiences they're going to have and test those strategies. And to other techniques that are actually trying to use role play and modeling to do some problem solving and learning of crisis intervention skills. There's been a large effort to kind of do these stand-down trainings to bring awareness and build that awareness among leaders, troops, and families about really what to expect, what they should expect across the deployment cycle, the types of experiences that they may have themselves, that they may actually observe in their loved one, and what to do about them. These approaches are often universal. If you think about the public health model, these are universal approaches. They're offered to everybody. And so you've got groups that have potentially mixed in their level of risk for how they might respond to these types of environments and experiences, but also large settings in many, many cases. So risk mitigation. There are many, many programs that have been put in place to specifically try and reduce the risk of certain negative outcomes. This, again, is done primarily through workshops, presentations, consulting with commands, and even embedding providers within units, trying to bring as far forward individuals that can identify problems and help mitigate them right at the forefront of the issue. They specifically target the reduction, often, in the incidence of psychological health problems. We see a lot of effort focused on specific problems such as domestic violence, sexual assault, substance use, and suicide. Again, I mentioned these are kind of public health approaches that are focused on a particular outcome, but many of them incorporate the concepts of resilience and teaching the techniques and skills that I talked about in terms of the evidence level, evidence-informed factors. So combat stress interventions, the idea that we need to identify those in need and connect them to care. So there are multiple screening approaches, both universal and targeted approaches that are used to try and identify those that may have signs and symptoms of problems. both far forward as well as when they come home. We've used, the military has used embedded providers within units. Chaplains have become a very critical workforce if you think about their role in being able to both provide a confidential source of support, but also being on the front within the unit to recognize changes and potential problems within the individuals and units they come in contact with. We've deployed in-theater combat stress interventions, teams, individuals that have the training to kind of provide the early interventions that might be able to provide some relief, symptom reduction, as well as promote recovery and return to duty. There's been a heavy reliance in the military on the use of gatekeepers, so individuals that will be on the front lines, potentially recognize the signs and symptoms, and be there to be able to connect individuals with help and get them facilitated into treatment. I mentioned chaplains are a critical gatekeeper. We also know NCOs, or non-commissioned officers, are also kind of down at a lower level in the ability to actually try and be aware of potential problems and connect individuals to help. There's a number of care coordination programs that have been implemented, particularly targeted toward higher risk groups, like for example the severely wounded, ill, and injured, have a number of different support programs that are designed to kind of help them with care coordination and make sure that they are getting the support and help that they need. And then the idea that there's also a number of things, public education campaigns and other kind of resources and materials that have been put out to really try and change the culture and create a culture of help seeking and kind of change the message, address kind of the concerns around the barriers to care about stigma, and promote a culture of help seeking, and as help seeking as a sign of strength within the military. And this has been a pretty radical and large shift over the past decade. So then finally, kind of the next typology of these different types of resilience programs are focused on treatment and reintegration. So delivering services to those that are in need and trying to facilitate their recovery, kind of trying to prompt that bounce back. You know, these come in the forms of crisis intervention, the delivery of evidence-based treatment for specific mental health problems for both service members and their families. So ensuring that when we know that there are researched, based, evidence-based, effective, high-quality treatments, getting them to the individuals who need them. This has primarily come through various different efforts, large efforts, to train providers and military leaders on the appropriate techniques to use, as well as the techniques not to use that we've learned from research that don't work and perhaps can be even dangerous. But then to also expand services to non-traditional settings, to think about being able to put some of these techniques in primary care-based settings or in other outpatient settings. They've created a number of kind of non-medical counseling services that are available to military service members and their families that can provide some confidential care and supportive counseling. But then again, linking with collaborative services. We often know that individuals who are in need don't just need health care. They may need other assistance in trying to get adaptations made to their homes, connections to help with any transitional issues for their children as they adapt to perhaps dealing with different challenges for the family. But also kind of providing support. We know that one of the most vulnerable times for individuals is during a period of transition. And so helping individuals as they transition from deployment, so as they come home, thinking about how we bring our troops home and what we do during that transition period as having an effect on their recovery and their transition back into civilian settings. But also kind of after they take that uniform off, after they leave their military service. This is particularly a concern for reserve and guard members who often don't have much time as they come home. They can come home and within 72 hours be back in their homes and maybe even be back in their employment settings if their job is still there. And so trying to think about how we really help them transition across those periods. And so again, there are multiple transitions across the deployment cycle, transitioning through pre-deployment, through the deployment, out of the deployment, as they come home, and then as they reintegrate and leave the military service. And then really thinking about that more long-term, they may even have more transitions after that. They may move from one location to a different location. And then there have been efforts to kind of really think about how we facilitate patient engagement. I think for those of you that study quality of care, we know that an activated, informed, and educated patient will be a kind of engaged in ensuring they get high quality care. So how can we ensure that when those in need or in treatment are getting services, that we are putting things in place that can keep them actively engaged and that we don't see dropout or challenges with compliance. There have been a number of innovative solutions now tried, again, to address some of the barriers around access to care, but also to kind of keep patients engaged in this self-management approach. There have been internet-based and smartphone approaches. I don't know if any of you have seen a lot of the new technologies that are available from, if you go to a couple of the different websites from the Defense Centers of Excellence, the T2, the technology branch, you'll see a number of kind of online internet-based and things that you can download to your smartphone that are designed to kind of help individuals assess their own symptoms but manage their treatment and recovery as well. So as I said, there are a number of different types of programs that fall into these different categories, and we tried to try and wrap our arms around everything DoD was doing in the area of resilience. So we used a very structured approach. First, we had to define what we felt rose to the level of a program. A poster isn't a program, but things that we're actually trying to do, interventions designed to kind of promote resilience. And this was a couple years old. We did this in 2009, 2010, and at that time we identified 77 resilience programs across the DoD and services that had in their mission to promote resilience among troops or their families. There are a number, I just listed a couple here that you may have heard of. Battle Mind training was a series of briefings that was used at the pre-deployment and post-deployment phases. It's now been renamed resilience training, and this is focused in the Army. The Army Center for Enhancing Performance is a kind of a performance optimization approach to help with specific techniques to help individuals perform better. Think about sports psychology to some extent when you think about this, you know, the use of imagery, self-regulation, helping building your focus and task to kind of accomplish your goals. And so this too has now been folded under another program that I'll talk about in a second within the Army. Airman resiliency training, similar to Battle Mind, this is a series of briefings that are delivered in large group settings within the Air Force. Combat operational stress control, it kind of refers to a whole suite of different types of approaches for the Navy and the Marines. It includes embedding providers low down within the units and far forward, but also kind of teaching combat stress kind of techniques to the Marines and the sailors. Project Focus. Focus stands for Families Overcoming Under Stress. This is a resilience training program for families and children within the Navy and the Marines. It's based out of Los Angeles, but they've been doing programs around a number of different installations. The Real Warrior campaign I mentioned, that's actually a public education and awareness campaign. It's got several components with educational materials, both for service members, for families, as well as healthcare providers at therealwarrior.net. And then Comprehensive Soldier Fitness. Comprehensive Soldier Fitness is now incorporated to kind of take under its realm kind of the concepts and trainings around Battle Mind, as well as the Army Center for Enhancing Performance. But Comprehensive Soldier Fitness was introduced in a few years ago on this idea that we needed to take a more holistic kind of approach to thinking about fitness that brought in what we knew about the mind and the body. There are 5 dimensions. Physical, kind of the idea that you want to perform excellently and capably in the physical domain. Emotional, social, spiritual, the importance of kind of having faith and spirituality and kind of a belief in oneself and their mission. And family. So they have 5 dimensions, but they also then base this on 5 kind of pillars, if you will. They use a kind of varied approach to try and both assess how people are doing along these dimensions, but enhance their fitness in each of those areas. They use the Global Assessment Tool, which is a survey that individuals are asked to fill out that assesses kind of how they're doing along these different dimensions. They train what are called master resiliency trainers to kind of be skilled and able to help individuals develop some of these skills in problem solving. Performance enhancement is another one of the pillars. institutional training, kind of helping leaders within the institution of the Army to kind of understand the importance of these concepts. And then kind of the use of modules to be able to allow individuals where they want to improve their kind of abilities in one of these areas to be able to take some of those modules. I wanted to kind of talk a little bit about comprehensive soldier fitness because as I transition into total force fitness, you can see that the Army was thinking about some of the tenets in comprehensive soldier fitness before and informed actually where we went with total force fitness in the military. So I mentioned these programs and I mentioned these concepts, but I think what's important is, like I said, billions of dollars have been put into these programs, but we still know very little about whether or not these techniques, these strategies are effective. When we did our report in 2010, at that time, very few of the programs had been evaluated. Those that had been most regularly evaluated included the Army's programs, Battle Mine and ASAP. They had demonstrated that those that had taken some of those debriefing and trainings had fewer symptoms of PTSD and depression and fewer sleep problems when they came back from deployments. And we knew at the time that ASAP was doing some very rigorous randomized controlled trials to look at program efficacy at a number of places. And so now they've been subsumed under comprehensive soldier fitness, and comprehensive soldier fitness itself is being evaluated, and there are a number of reports that have both come out and some ongoing efforts to kind of ensure that what is being done is being efficacious and effective. I'll note that I think program evaluation is critical, and I think it's important to acknowledge that in an effort to kind of rush out and have well intentions to help folks cope and deliver these services, few programs actually think about asking the question, well, did it work? You know, or how could we do it better? Resources are often not allocated for program evaluation, and we're kind of been in the mindset that we just have to do something to help to try and solve these problems. We can't wait for the data to tell us if it's going to work before we roll it out. We just have to roll it out. The programs that have done some evaluation tend to use different types of strategies. They gather satisfaction data on using feedback and from ratings and interviews with individuals who have participated in those programs to understand the feasibility and inform improvement. Some programs actually gather information about functioning across a number of domains, typically in the emotional and behavioral health area. They ask questions about post-traumatic stress symptoms or antisocial behavior and things like that. Again, they also gather some clinical data. And then most of the outcomes that are measured, though, around these programs are focused on the individual level. There are fewer programs that are focused at the family and organizational level, and very few that actually assess kind of how families think things are going. Project Focus has done a number of evaluations, and they've had a number of reports published about the effectiveness of their program as well. Again, most of the programs kind of focus at this individual and unit level. Again, around positive thinking, kind of behavioral control, and creating that positive command client, kind of helping leaders to try and understand and provide both positive role models and reinforce the importance of taking care of yourself. Family communication and belongingness are also the most commonly incorporated factors for programs that are focused at the family and community levels. So now I'm going to turn to talk a little bit about total force fitness. And total force fitness is a relatively new concept. It was introduced in an instruction from the Joint Chiefs of Staff in 2011. And it really tries to incorporate, again, different dimensions that focus on the mind and the body. And so we have a number of domains. It's a holistic approach. It's really an emerging framework that's helping to kind of organize and think about kind of fitness in a more holistic way. There are 4 of these dimensions that focus on the mind: psychological, behavioral, spiritual, and social, and then 4 that focus really around the body: the physical, the medical and dental, nutritional, and environmental. And I'll talk about each of these in a second. There are 5 tenets that really underlie this concept, that total fitness really extends beyond the individual. It involves families, it involves communities, it involves organizations. That the family's health plays a key role in sustained success and fitness for the individual and for the force. That in implementing this and assessing it and using metrics, you not only must measure the positive, but you also must measure the negative outcomes. And it links to the concept of the forces fitness to the fitness of society from which service members are drawn. I think it's important to think about, our military is recruiting and accessing individuals that come from the United States society. And as that society struggles with its own challenges and issues around fitness and health and well-being, that potentially creates challenges for the military to either try and correct or enhance or address some of those issues as well. And so this really does kind of take a societal approach. And throughout this kind of approach, it really acknowledges that leadership is absolutely essential. And if you've heard anything kind of about these various different things within the military, leadership is a critical element of almost everything that they do to support their troops. And it can have both positive and negative impact. And so I think that's an important takeaway. So what is physical fitness? I think this is probably the easiest for all of us to identify with. It's the ability to be able to accomplish all the aspects of the mission while remaining healthy and uninjured. Well-rounded fitness programs are going to have varied kind of approaches to kind of cardio, strength training, building the core strength, increasing speed and agility. But it also acknowledges that you need the appropriate amount of sleep to perform well physically and to facilitate recovery after different events. And in the total force fitness concept that was outlined by the Joint Chiefs of Staff, kind of talks about the use of mind-body programs as being just as important as that strength training, the concepts of yoga, martial arts, and meditation, for example. Some of the ways that physical fitness is often measured, you can think about strength, speed, agility, and kind of, the ability to your body composition, kind of your aerobic capacity, kind of all the traditional kind of biomarkers that we tend to take, that we can measure kind of on the physical person's performance. With the goal of training your body to be ready for the mission and the job. This is why you see a lot of PT programs and a lot of focus on individuals' physical strength and appearance. Psychological fitness. Again, this really kind of draws from what we just talked about in the prior segment about psychological resilience and kind of now calls it psychological fitness. This is the idea that you can integrate and optimize kind of the mental and emotional behavioral abilities and capacities to strengthen your resilience but optimize your performance, to kind of both be able to focus and perform, but then also to perhaps strengthen resilience. The ability to cope with unique mental stresses and challenges. And then it also kind of presumes that without this resilience, service members and their families are at risk of burnout. They can put themselves at physical danger and may be more vulnerable to stress and combat-related environments in particular. Some of the metrics here kind of, think about not just the absence of psychological symptoms, but think about aspects around morale, adaptive coping techniques, and kind of mental capacity as well. Is just the absence of psychological disorders. Behavioral fitness, this is really about what we do to our bodies and how we behave, whether or not we adopt behaviors that support readiness and health, and thinking about positive behaviors, increasing kind of the things that we do that are healthy, and decreasing the things that we do that perhaps are less healthy, like smoking and use of substances, or risk-taking behaviors, wearing your seatbelt, wearing a helmet when you ride a motorcycle. And so the idea that behavioral fitness is really about making sure that individuals are making healthy choices in how they interact with the environment. Spiritual fitness, the concept of finding meaning, purpose, and then social support. This isn't necessarily about belonging to a church or any specific religion. It's about the individual or group's ability to maintain their belief system, the principles and the values that they need that will help them in times of stress. And really kind of their philosophical and human values. These concepts we often think form the basis of an individual's character, their disposition, but really also kind of influence their decision-making and their integrity at the individual and group level. Again, this is about values and practices and core beliefs and finding meaning in tasks and in life. And a lot of the literature talks about the importance of that meaning and value. Social fitness is the concept of building and maintaining healthy relationships with others. If you think about the ecological model, it's kind of how the ripples out support you at various different times of need. You know, the ability to engage in social networks in a healthy way that promote overall well-being and optimal performance. It really intertwines, again, that the unit, the family and community levels with the individual. And the idea that this really comes in the social fitness is developed around the common sense of purpose, clarity of the values at the personal level as well as within a unit, the understanding and awareness of the mission and the preparation for challenge and kind of how this all relates together. This is often measured kind of in concepts of social cohesion, social connectedness, kind of task cohesion when groups are assessed to the extent that they're kind of all integrated into that social network. Medical and dental fitness actually really refers more to meeting the minimal standards and requirements that the military sets out to ensure that individuals are deployable and that they meet the minimal requirements for retention in the military. And there are a number of them. They vary across the various different services, but they basically fall into the categories of, you know, are you free of disease and are you fit and healthy to perform the specific tasks that are designated in your occupational specialty. So they employ various different screening techniques, an immunization program to kind of inoculate and immunize individuals against particular types of diseases as well as hazards that they could be presented with. And they focus a lot on prevention and pre-treatment. So when they screen individuals and they identify something, if those can be treated, they will deliver services and interventions that can then bring them back up to medical and dental readiness. And again, it's focused on ensuring that the service member is capable of completing the required training. You know, can they endure the basic training, but also other mission-related training and environments to effectively perform the requirements. Again, we count on our force to be able to perform effectively, and we need to make sure that they can endure that training to prepare. Environmental fitness kind of acknowledges and recognizes that the environment within you work has a very, very big influence on how well you can perform. Again, you know, we know that our bodies perform differently at different temperatures, at different altitude. Noise can play effect on our ability to focus and get tasks done. Air quality, radiation. This doesn't just apply to the military, it applies to all of us. I think we can all think about the settings in which we find ourselves working more effectively and being able to accomplish our tasks. But within the military, we also know that they may go to environments where they may be exposed to specific hazards, such as hazards that may come in, you know, both exposure to toxins, they can be vector-borne diseases or other contaminants. And so, you know, there's a focus on the use of not just the immunizations that I talked about before that can be effective in preventing some of these consequences if they come in contact, but the use of personal protective equipment and kind of specific adaptation and training techniques that are required so that individuals can perform at these different levels and be able to kind of perform their tasks and mission at different temperatures, at different altitudes, again with noise, and really kind of focus, if you think about it more, kind of around occupational health and safety measures to kind of both provide that prevention and intervention where needed. And nutritional fitness, which I think is also gaining more and more recognition about being very important about the provision and consumption of food that both in quantities and qualities and proportions that are sufficient to preserve performance and health. But thinking about making wise choices nutritionally, not only about the food that we consume, but about the supplements that we put in our body. The supplements that may have positive effects as well as the supplements that may have negative effects. And there is for any of you that have had the opportunity to deploy to some of these environments, there's a high reliance upon those energy drinks and the caffeine to kind of keep folks awake. Trying to understand kind of how that changes an individual body's performance and kind of the effects that that can have, both positive and negative. At the same time that there are some nutritional supplements that we believe can confer some benefit and perhaps be protective against some challenges in stressful environments as well. So again, trying to create a culture, an environment where healthy food and beverage options are an easy and appealing choice. This is difficult. I think for any of us that have tried to make healthier decisions about what we eat, it's difficult when you travel. It's difficult when there are few choices at grocery stores or you're in a hurry. Thinking about kind of how you array food items in grocery stores,
but what's available and what's cheap at the exchange, and how are we really kind of thinking about policies and programs around promoting healthier choices in what we put in our bodies. So I'm going to talk a little bit about kind of what the implications are, and invite your comments about kind of what you think the implications are for non-DoD settings and environments and populations. I think that it comes without saying that I think we all recognize the role and importance of using public health approaches to try and understand a problem, use both universal and targeted approaches to screen, detect problems, and treat and facilitate recovery. But I think the importance of what we've learned over the past 10 years and kind of where these concepts have gone from not just resilience promotion, but also in psychological resilience, and thinking about this all as something that we need to do to train people to just deal with stress more effectively, but how we think about fitness in a more holistic way is the importance of recognizing that there are multiple dimensions and layers that contribute to health and performance. It's not just about how we think about things. It's about some of these other dimensions. It's not just the individual, it's their family, it's their unit, it's their community, it's the environment that surrounds them. And so these multiple layers and dimensions are critically important to think about, and how that intersects with what we're trying to do, particularly in the healthcare field, where we're only touching individuals for a very small portion of their life, and that the other parts of their life may have greater impact on some of their decisions and some of the outcomes. Again, the opportunity that we have to think about promoting resilience and teaching techniques and teaching skills, just better decision-making skills, problem-solving skills. Not just for our military, but what about our children and the next generation of adults? And what are we doing to think about how we help individuals in various different communities approach situations and kind of make healthy decisions and support one another with these concepts of resilience that will be helpful, I think, for maintaining population health more broadly, preparing specifically for disasters and emergencies to minimize trauma. There's been a large effort, and if any of you have read the National Health Security Strategy, the concept of resilience is clearly and squarely in there around communities and thinking about how can we prepare communities that may be living in regions that could be at higher risk for some of these disasters, or that may, over time face some of these community challenges, and kind of thinking about, building community resilience, that they can kind of prepare, work together to create the solutions and adapt successfully. And again, thinking about the opportunity that after an event, resilience again and some of those techniques can help foster recovery for individuals, for the family, and the community. And then again, this concept of the need to measure the effectiveness continually, not only to inform continuous improvement, to kind of ensure that we're getting better, more efficient, and we're ensuring effectiveness, but because we want to minimize, we often have to be concerned about the costs and how well and how long these things can be sustained in terms of the level of effort. So we want to be cost effective, but I think we also want to ensure that what we're doing and what we're deploying in terms of these programs work, so that we can offer folks the most hope and the most promise for being able to cope with the very challenges that they will face, and that they can facilitate recovery, transition into civilian life, and thank them for the service that they've given to our country, not just them as individuals, but their family as well. So I think it's critical that we always ask ourselves the need to evaluate. And as I said, resilience for a long time has been thought as the panacea. If we can just make folks resilient, then we won't see these rates of PTSD, we won't see the rise in suicide. And that may be, but we have to actually start to measure whether or not some of these techniques are in fact accomplishing what we hope that they will accomplish, and if they're making a difference. Not just by measuring the absence of some of the psychological health problems, but looking if they contribute to some of the health and fitness domains that we believe they can also be associated with. And I'm a great believer in resilience. I believe it's a concept that is important and that we need to strive for, but I maintain some healthy skepticism as well, and that I hope that we can continue to refine what we believe are techniques that will promote resilience, that will enhance fitness, so that we can kind of really make sure our troops and their families are given the very, very best that we can. And I thought it kind of effective and important that as I was thinking about this talk and these concepts, that I saved my talk on my little Nemo drive, because Nemo, after all, is one resilient little fish. And so, let's hope that we can all kind of ensure environments where the little Nemos can kind of get back and endure a very traumatic experience. And for our troops, I think we owe it to them to ensure that the techniques that we employ and the strategies can help them endure the great sacrifices that they're making on all of our behalfs. So with that, I'd like to open it up to questions. I'd be happy to kind of go over anything I just said, and I guess for those on the web, we would just remind you, and for in the room, to please use the microphone so that folks on the web can hear you, and that you have an opportunity to send in comments online. Do I put that other slide up, I guess?
Terry, thank you. Is this on? Is this on? Thank you for your presentation. The topic of resilience is really interesting, and I've heard you speak before. How does your kind of collective approach, either through the current Total Force Fitness or the other programs, evolve or change in relationship to those who are doing back-to-back deployments, and the needs of those individuals, and how you go back and assess the needs and shape your program again and really get to that individual and their community, family, whatever?
That's a great question. At RAND, we aren't delivering these programs and services. We have the opportunity to evaluate them and kind of, look at how that's affecting some of their kind of approach to changing kind of techniques. And, I think it's an open question. I think there's been a lot of concern about the repeated deployments, the kind of accumulation of time spent away from families, time spent at risk for significant exposure to trauma. And these programs are anchored to various different parts of the deployment cycle. And if you even start to think about the way that they assess, somebody could be doing a pre-deployment screening, but they've already deployed 3 or 4 times. And so is that really pre-deployment, or is it post, 3 deployments? And so it's hard, I think, to kind of think about these things linearly, because we start to get into a circle and a loop. And I can't speak to what some of these individual programs are doing to kind of think about that and how they change their techniques, but I can say that there is a general awareness that the accumulation of exposure is becoming more important, and the need to kind of reconsider guidelines for how we deploy individuals, both the number of times, for how long, how much time do we give them back home, what do we do, what can we do with interventions and strategies while they're back home that can help reset them and kind of, put them on a path, but prepare them that that path may be interrupted with having to go again. And so thinking not just about the individuals, but the family. So I don't have a direct answer about specific things that are being done, but that it is an ongoing challenge given the environments where we're deploying people multiple times. Any other questions?
Terry, thank you very much. The title of your presentation was actually a little provocative because you used the term evidence-informed. So RAND is one of the biggest evidence-based practice centers that we know. What was the decision to use the term informed as opposed to based?
Because the strength of the evidence really isn't there to indicate. We don't see that a lot of the, there just haven't been a lot of research studies that have used the designs that we would use traditionally to use the term evidence-based. Like I said, we don't have the opportunity. There haven't been a lot of RCTs done to indicate that this actually demonstrated a real efficacious approach. And so evidence-informed we use to kind of suggest that there is evidence. There's, in fact, we reviewed hundreds and hundreds of literature. The strength of evidence varies across these different factors. But a lot of it's theoretical. A lot of it's post-event, kind of observational. It's hard to draw causal relationships between, some of these factors and the outcomes based upon those designs. And we talked to experts. So we felt it's safer to call it evidence-informed versus evidence-based, which traditionally you would see in other parts of the field where there have been a lot of RCTs that have demonstrated efficaciousness.
This is not unusual to this area. At the end of the day, people still have to make decisions, and I would imagine that in a setting like this, people still have to make decisions about what interventions to actually use or what strategies for education. So are you able to at least give people a sense of what the strength of the experience is, and to guide the military in deciding which approaches to use?
Yeah, with that one part of the talk in terms of the study that we looked at, we did provide very specific recommendations at the program level. We could identify the various of the programs that we looked at, what factors were being used, if those were the factors with a stronger level of evidence versus a lower level of evidence. And that feedback was given with the opportunity that they could actually think about changing their approaches, incorporating some of the other factors that, according to the evidence to date, suggests will be have greater potential of promoting resilience. We haven't been asked to go back and evaluate again whether or not that's in fact happened. We've had a newer study that has looked at psychological health programs more broadly. And again, great challenge in thinking about, yes, you need to make decisions, you need to deploy interventions, you need to get these services out there. But how are we incorporating kind of a continuous quality improvement model to that process to ensure that we're always refining strategies to focus and target and improve? And so we provided at the program level, specific recommendations, as well as more broadly for the field to really think about, should there be sets of expectations or approaches that should be focused on more heavily than others. Again, I think this skills development and the teaching of techniques is different than lecturing and putting slides up, and certainly having, rooms of people with PowerPoint slides going up while they're actually trying to accomplish something else, which we've also seen happen. And so we've given some feedback on specific methods and techniques for how you actually deliver the information as well.
Deborah, are there some comments?
We have a comment from the viewers. Tell me if you can hear me now. So this question is, what approaches are being used for service members who've left the military or guard members at home away from their units?
So that's a great question. And there's a pretty well-known program now, the Yellow Ribbon Reintegration Program, that was implemented a few years ago, specifically designed to target and provide support services for reserve and guard after they come back into their communities. And the Yellow Ribbon Program offers a range of different types of programs and services, and each state has a different Yellow Ribbon program and can do things a little bit differently. I can't speak to specifics because I haven't studied the Yellow Ribbon program, but it does exist, it's out there. And there are a number of programs that even the services have now tried to deploy that focus on individuals after they leave the service. And so not just thinking about people while they're in uniform, but thinking about them as they make those transitions as well. So Yellow Ribbon is certainly one of the ones that's most well known. And then, there's some efforts I think that have been put out by the VA, obviously around, suicide prevention and crisis, but also transition to kind of have more welcoming hands for individuals as they come from the Department of Defense as well.
Hi, Terry.
Hello.
Can you hear me?
Yes.
Okay. My name is June. I have a question, obviously. You mentioned that during your briefing or in your overview that you have a healthy skepticism in terms of the effectiveness of the various techniques of resilience. And earlier when you were discussing the comprehensive soldier fitness, you mentioned that physical, emotional, spiritual, family, yada, yada, that there's a training for the master resiliency for all the trainers. Did your study by any chance go into perhaps the effectiveness of those trainers and the master trainers, if you will, in resiliency and the effects that they may or may not have?
That's a great question, and no. We actually did not evaluate comprehensive soldier fitness as a program. And I know that there are some ongoing assessments that that team is doing with some partners, but RAND is not engaged in any of those evaluations, so I can't speak to that question. I'm sorry.
Are there any other questions from people in the audience or any others on Twitter? If not, on behalf of the Office of Disease Prevention, I'd really like to thank you for having given us a stimulating presentation. It's very fitting, a fitting component of our Mind the Gap series, and it does challenge us to think in different ways. At the same time, I'd also like to thank our other co-sponsors of this seminar, the Office of Dietary Supplements, the National Center for Complementary and Alternative Medicine, the National Institute of Mental Health, and the National Institute on Alcohol Abuse and Alcoholism. They have been steady partners through all of these seminars. We're very grateful for their participation. Audience, thank you very much for your participation. Everybody who's here or on the web, please follow Harris's suggestion that if you identify topics and speakers whom you think would be appropriate for this series, we'd love to hear from you about them. And on a personal note, I want to thank the Office of Disease Prevention for having let me be their director for the last couple of years and let me be involved in activities such as this. It's been really quite an exciting ride. So thank you to all.
Thank you.